name is Dr. Eugene Vortsman. I am an emergency medicine physician as well as addiction medicine. My title is Clinical Director of Addiction Medicine and Disease Management. I'm the chair of the pain committee for Long Island Jewish Northwell.
For psychedelics, it seems like maybe historically there's been like a hesitancy to employ these, maybe a little bit of due to the general feelings or sentiments around that area. Is that something that's kind of correct, or is that something you could elaborate on a little bit?
Sure, absolutely. So historically speaking, we did what we always do. We overdid it, right? So LSD in the 60s ended up being Tim Leary, the psychologist from Harvard, says it should be in the water. And it was, I think, too much. It needs to be respected like everything else. But we can't prohibit it. We shouldn't throw people in jail for victimless crimes. And we need to be able to bring it into the spotlight for so many reasons. Regulation is important to keep it in line. And so there's reason for it because we've overstepped in the past about how accessible it is. And the truth is, in my opinion, just like cannabis and psychedelics, we need to respect it. It has its potential, but it definitely has its pitfalls. And I think that that's why I'm excited that this is done in the right way with FDA, with the government involved, with descheduling, right? So that we can really have a good open conversation about how we're going to move forward with these new medicines.
So we see there's other compounds like botulism toxin. Historically, we're all taught this is a toxin, right?
Yeah,
so
sure.
it has this negative connotation, but it's made its way into migraine treatments and
Totally.
aesthetic treatments.
Absolutely.
So how is this different, and what could be done from a development or regulatory standpoint to sort of bring psychedelics into an equivalent position? And what would that look like?
Right. So what botulism, let's say the botulism toxin is a great example, right? We found it to be dangerous and floppy baby syndromes with kids and honey, right? But what we didn't have is we didn't ask the right questions to get the right answers. We didn't invest the right things. And so what we're seeing now with psychedelics and what we haven't seen yet with cannabis and what we hope to see with cannabis is FDA trials, randomized controlled trials, to be able to know exactly what lane these medicines should be in. Botulism obviously should be something careful with honey in children, of course. But the ability to help people with migraines without giving these medicines that make people sedated zombies is amazing. That's incredible. And what we're seeing with drugs like MDMA and psilocybin, antidepressants don't work on 35% of people who take it. And we find that out after a month, 2 months, 6 months of giving people. I wouldn't do that. I wouldn't give a medicine like that for anything. Imagine I gave an antibiotic that only worked 75% of the time or 65% of the time. I would be laughed at. And here we created a standard of care here that is a medicine that doesn't work a third of the time. And so there's this really amazing studies that come out with psilocybin, major depressive disorder, or MDMA and PTSD. We need to ask the right questions, put the drugs in the right lane, and be able to do it in a guided way. And I believe in the spotlight. I believe the regulation is important. And I think that's where I'm really optimistic that these are going to be, you go in for one dose and you feel good for 6 months compared to these daily medicines, these daily antidepressants that don't work for a third of the people. And forget about it, even if they do work, their side effects are so tough for so many people and so many families and so many jobs and so many, just the way these people need to live that I don't know if it's the right answer, but I really want to know. And I think it's important for us to put the right resources, money, and accelerate that research so we can get the right questions as fast as possible.
One of your presentations, it says that there's no large RCTs on cannabis, for
Yeah.
example. Mm-hmm. And, you probably need these to confirm medical benefit from a regulatory standpoint.
Absolutely.
So I'm wondering, why do you think the large RCTs aren't conducted on this? What's holding this back from entering traditional routes of development and approval?
We learned a lot of lessons from COVID, positive and negative. And one of the important lessons of how we developed the vaccine, we found out all the issues with vaccine development. And a lot of it was the red tape. A lot of it was the lack of resources, lack of volunteers to do that research. So when a drug is a Schedule I drug and it says, hey, this drug is only addictive and has no medicinal benefit, which we know is not true, we need to be able to, so to speak, open up that NIH funding, which funds almost 85% of research in this country. And so once you declassify and deschedule the drugs, which is just now, 2 weeks ago, we're in September, just really saying the FDA is doing a recommendation to take it from Schedule I to Schedule III. That would open up a world of RCTs and a world of kind of opportunity to ask the right questions and get the right answers. And so that's what I'm hopeful for a future in regards to getting those RCTs and doing it right, and I'm very cautious and fearful with normalization of cannabis, and especially with children, honestly. And I'm also very hesitant on the strength of the cannabis, right? Because it's being targeted towards these frequent utilizers with this 35%, 95% THC. It's too much. It's too strong, and it's going to have its side effects. And again, goes back to why bringing it into the spotlight, creating regulatory processes that are sane and logical gives us an opportunity to take care of our patients better, and especially pain.
That's great. That's great. Is there anything else that you'd like to cover that you haven't covered? Any questions that I should have asked?
I should have asked. Well, let me just think about it. Just, what I've been excited about with Pain Week. My first lecture at Pain Week actually was misinformation during the time of COVID, actually. And I actually discussed about the both sides, so to speak, of what we were talking about. And then since then, we started talking about the opiate crisis, and then we started talking about psychedelics, and now we're talking about cannabis. And what's always been really exciting about Pain Week and Brain Week as well is the openness to have new conversations and be able to use venues like this to reach people from across the country, and I think across the world. And so Pain Week has been super well organized, and everything is a tight ship, and it's always a pleasure to be here. So I really want to say thank you for having me.
Yeah, of course, and thank you for joining us.
Yeah, my pleasure.